Welcome to the Inspired Caring Podcast, where women who are in the messy middle of this big, beautiful, and sometimes chaotic life are finding inspiration and resources to care for themselves and figure out the best options to care for their aging loved ones. How we take care of ourselves today impacts how we are aging tomorrow. This podcast will help you feel seen, centered, and aligned. Everyone that relies on you is so lucky to have you in their life. The Inspired Caring Podcast is your reminder that the number one person that counts on you is yourself. Congratulations on being here in this moment. Let's dive in and be inspired. Today on Inspired Caring, we have Donna Kerber with us, and Donna is a wound nurse. And I am really excited to have this conversation because wounds are something, as our loved ones get older, that there is potential for them to experience. And honestly, one of the things that I learned from an insurance company that insures senior living communities is wounds tend to be at the forefront of the conversation when people are considering a lawsuit.
Yeah, wounds. And I think second would be falls.
Wounds and falls. So
Yes.
I'm really excited to get educated today about wounds and just learn more about it. So thanks for being here, Donna.
Thank you, Michelle. I am very excited to be here. I've been very passionate about wounds for decades, actually.
Yeah, share with us a little bit about your background because I know it is extensive.
Yes. So I've been an LPN for 36 years. I have spent 17, going on 18 years of that now in wound care. My background includes certification with the American Board of Wound Management, which is the credentialing organization for physicians, nurse practitioners, RNs, LPNs. And I am was certified wound care associate. I'm heading towards retirement now. Also a diplomat for the American Professional Wound Care Association, a fellow with the American College of Clinical Wound Specialists. And then I served 2 terms on the American Board of Wound Management exam committee to determine standards for future wound care associates. So I've been on both sides of it.
Yes, you have. Well, that is impressive, obviously.
Thank you.
Needless to say. Can you maybe just start with what exactly is a wound? I'm using that word pretty liberally, but what is it?
A wound is basically damage to the skin. Sometimes the skin will be open. Sometimes the damage has already occurred underneath. You could have a wound and not even realize that it's there, particularly with pressure. But a wound is just a breakdown in skin tissue. I mean, at its simplest form. There are different kinds of wounds. There's traumatic, there's surgical, there's venous, there's arterial, there's pressure,
So with pressure, is that a bruise? Is a bruise a wound, or is that something different?
No, a bruise is damage to vessels that are immediately under the skin surface. And that's where you get the discoloration is you damage the vessels. Like if you hit it, like say you bump your arm and you get a bruise, you've damaged the vessels underneath. They've broken open, they've leaked some blood out. And that's where the discoloration is coming from. So that isn't something we would classify as a wound as much as an injury.
Okay. So you mentioned there's different types of wounds. So
Correct.
how can a wound start? What could be the origin?
So depending on age bracket, the most common would be trauma. And that would be you hit your leg or you run into a table or you stub your toe and break it open or you step on something, that type of thing, like a car accident. From there, then as we age, or if you have other comorbidities such as diabetes, peripheral vascular disease, arterial disease, poor nutritional intake, dehydration, that starts setting you up for risks for other types of wounds. So, for example, with diabetes, you would have a higher risk if you're not taking care of your diabetes because you can get neuropathy and you might start to lose sensation in your feet. When that happens, you might step on a rock and not realize that you've actually caused some damage to the tissue, and then you keep walking on it, and it actually can then become an open wound. The most common way I've seen diabetic foot wounds diagnosed is when patients take their sock off and they see blood or pus on their sock. We encourage diabetics to always check their feet every single night, be diligent about it, because that's how you find wounds the quickest and can then get them taken care of and prevent amputation. But a lot of people, unfortunately, don't follow this advice. And so they'll see the blood on their sock and they'll go, oh, what's this from? And then they find a wound.
Okay.
So
that's a good transition into what should people be looking for. So obviously, sometimes people are caring for a loved one at home, either in their home or their loved one lives independently. And so they're like commuting to go help them occasionally. And then sometimes people are living in senior living. So I guess just like as a family caregiver, would be some of the things that we could be looking out for?
it would go back to underlying diagnosis, and then the other components are mobility and continence status. Do they have urinary incontinence? Do they have bowel incontinence? So big picture, you're just kind of doing a skin sweep, if you will, looking over them. Hydration is so important, so lotion is important. As we talk about that, when you're putting lotion on the feet, you should not put it between the toes because it doesn't absorb well, and that can become a bed for yeast to develop between the toes. So no lotion between the toes unless you make sure you wipe out any residual really well. It's just a preventative thing that most people are not aware of. So you're looking at hydration, you're looking at nutrition, making sure they're getting enough to eat and drink. Protein is the number one most important intake source that they need to have in terms of nutrition. Beyond that, you are going to look at, again, skin sweep, you're going to look at their tissue. If they aren't moving around a lot, you want to check for reddened areas, particularly on bony prominences. So the hips, the ischial bones, which is the bones that you're sitting on your butt, your tailbone, if they have any kind of curvature in their spine and they're sitting, back in their chair all the time, look at that curvature, look for reddened areas, and not just red, but does it blanch? So you're going to take and you're going to push down on it for 3 or 4 seconds, let it go. It should be white when you let go and then fill in rapidly. And if it doesn't, that's an area for concern. That's what we would call a stage 1 pressure injury.
Okay.
So
that's really helpful. I know that especially in senior living, people like the wounds I consistently think of are bed sores.
We call those pressure injuries.
Okay. So how can those occur? Like where can those develop from?
Anywhere there's a bony prominence.
Okay. So is that like my elbow is a bony prominence?
Correct.
Okay.
Your elbow, your shoulders, if you're laying on the back of your shoulders, the back of your shoulder, the back of your head, between the knees, between the ankles, literally anywhere there's a bony prominence and there's pressure on it, you can get a wound. We even have people that get pressure injuries behind their ear from oxygen tubing.
Oh.
Or the tops of their ears because the tubing is pulled too tight. You see people that like to have that tubing really tight and cinched up under their chin. They don't want it to be loose or moving around. We discourage that, and we encourage them to leave that a little bit loose because when you pull it too tight, you can get an injury from the tube pushing down on the ear.
Oh my gosh. So with the what did you refer to them as? Bony prominence?
Prominences. Yep.
So I'm just thinking with those, can they spontaneously occur? Are they a symptom of neglect? Like, how do those manifest themselves?
There is only one type of pressure injury that spontaneously occurs, and that is called a Kennedy terminal ulcer. That is someone that's a whole nother conversation.
Okay.
And that is someone who is going to die within hours.
Okay.
And what you can see in that, because the skin is the largest organ in the body, it's also one of the first to start to shut down. And when someone is in their end stage, what you will see is a cloverleaf shaped pressure injury show up over their entire tailbone, their sacrococcygeal area, and it will just turn black, usually within a matter of hours. And as I said, that person is they're already heading into the end stage. So the caution there for families would be, don't think they were neglected because when they died, they had this big area.
Mm.
That is just something that, again, it's called a Kennedy terminal ulcer, and it usually occurs. It doesn't happen very often, but if it does, it's easily identifiable, and it is from the death process.
Okay.
Beyond that, you don't have spontaneous occurrence. You usually have warnings. You have the reddened areas.
Mm-hmm.
You have other indicators like poor hydration, nutrition, those types of things. However, that being said, you can develop your stage 1 pressure injury within a couple of hours. And stage 1 is red but not opened, but not blanching. And that's the key. If it doesn't blanch, it means it's lost circulation to the area. And the only way to treat that is to get them off of it. So if they're spending all their time sitting in a recliner, and we have a lot of residents that like to sleep in recliners, the risk there is that they're doing that constant downward pressure on their tailbone, and it puts them at a much higher risk. And then if they do get a stage 1, you've got to get them off of it. You've got to get them out of the recliner, and then you run into resistance. And so you start looking at other things like specialized pressure relieving cushions and gel cushions. And most people don't realize a single cushion can cost between $400 and $800.
Oh my gosh. Can we like tuck pillows in a certain way, or
if you can get them to shift off of it and they're comfortable, yes.
Okay.
So
you refer to
don't ever use a donut.
Oh.
You've seen those donut cushions?
Yeah.
Well, the problem is that if they get on that and they fill the whole donut with their body outline, it cuts off the circulation. And then you're going to end up with skin tissue damage from no circulation to the entire center. So just never use a donut.
That is a good tip. I mean, that is a hot take.
I don't think we've talked about this before.
No.
But yeah, so we have families that will bring in, I brought mom a donut. I hope it's one to eat because we're not sitting her on it. And so.
Because that sounds like you're just creating a new problem.
You are, absolutely. Donuts create new problems. Absolutely.
Okay.
Yeah.
Okay.
Because it cuts off circulation. The center of that donut, it's almost like a suction cup, and the butt drops down into it. And then it just cuts off the circulation, and everything hanging in the middle is not getting enough blood flow.
Oh my gosh. Okay.
Yeah.
So how many phases, did you refer to it as a phase? How many phases of wounds are there?
So there's 4 stages, and then what they call unstageable.
Okay.
And it depends on the depth of tissue damage. So stage 1 is closed but not blanching. Stage 2 is pretty superficial. And if you can catch it at a stage 2, and that's the most common and also the most difficult to prevent, just because when you have someone who's already at risk, that's the easiest thing to happen. But if you can heal it at a stage 2, it also heals the quickest within a week or 2. Stage 3 is getting into the fatty tissue, and stage 4 is the worst. That's where you've got muscle breakdown and you're seeing bone. So, and then the unstageable is when it's covered with what we call slough or eschar, which is dead tissue. and it can be yellow, brown, black. Sometimes you'll see that hard black. That's when it's unstageable. If the wound is completely covered with dead tissue, we can't determine how deep it goes.
Mm.
So
I'm afraid to ask how you find out how deep.
you have to get rid of that tissue, and
Yeah.
that how you do that depends on where it's located, and are they on blood thinners? Are they do they have an infection going on? So typically, depending on where it's located, you would do like a sharps debridement, so a scalpel, curettes, get rid of that tissue, and then apply some type of debriding application. So it could be an enzymatic, which is a chemical debridement that goes in and breaks down the tissue, or it could be through the use of moisture to break down the dead tissue. What you have to be careful of is when you have a very moist wound, that you don't let that moisture seep out to the healthy tissue, because it will also break down healthy tissue. So once you have a wound, all of the tissue around it is compromised.
Mm. So if we're at home, like what, and we've identified, okay, we have a problem here.
Mm-hmm.
What should people be doing?
The first thing they need to do is, if it's on a bone of prominence, get rid of the pressure. So
Okay.
be shifting them. And then you're going to need to seek some type of medical intervention, whether that's home health care, whether it's contacting your physician. You need professional help at that point. If the tissue is open, you're going to need help. There are some things you can do, like for a stage 2, the superficial injury, but I would make sure that your primary care physician is aware of it, and they may be able to give you some direction or send out home health. There are simple dressings that you can put on it. The key to wounds is, if it's dry, you want to add moisture, and if it's too moist, you need to dry it out. You got to kind of find that balance, and there are literally thousands of products out there. And it's just having someone come in and go, okay, we need to put alginate on this and cover it with a bordered gauze dressing, or this is entirely too wet, we need to put a foam dressing on this. And it's just knowing which one needs to be applied.
And I know there are companies that have like a mobile wound management, so that's
Mm-hmm.
something worth investigating for families. And I mean, calling the doctor, I think, is really important. How do we know when it's time to call the doctor? Like, or if I'm at home and am I allowed to put antibiotic ointment on something? Or,
You wouldn't want to use an antibiotic ointment unless it was infected, because
okay,
otherwise you can create antibiotic resistance by placing an antibiotic ointment on it that it does not need.
okay, all
Yeah.
right,
So when you're using, like, say, a triple antibiotic, let's say you cut your finger open, you can wash it out with soap. First of all, wash it out with soap. Always, always, always. I have so many stories I could tell you about patients who did not wash the simplest wounds with soap and water, and it dramatically
hmm,
changed their lives. Don't use hydrogen peroxide. Hydrogen peroxide. Don't.
okay,
That is a myth. Hydrogen peroxide destroys healthy tissue. People think, oh, it's fizzing, it's killing the bugs. No, it's just fizzing because it's a chemical reaction with the blood in your body. It actually destroys healthy tissue. So just use soap and water
okay.
and clean it. And I'll share one quick story with you, and you can edit this out later if you want to.
If it's too much.
But I had a lady in her 80s, and she was walking along. She had a glass top coffee table, scraped her leg on the corner of it, didn't cut it or anything, but you know how you can scrape and you just get like that superficial abrasion?
Yeah.
Well, that is what she did. She didn't think about it. It wasn't bleeding. It was just scraped open a little. She kept on going. She ended up with necrotizing fasciitis, which is the flesh-eating virus, from that little table scrape,
Oh my God.
because bacteria lives everywhere. Not only did she end up with it in that leg, but it jumped to the other leg, which is very common. She ended up having to have the tissue removed. First, they were going to amputate, but we where I was at, which was Select Specialty Hospital at the time, they are amazing.
Mm-hmm.
Um, we had a physician there that said, I think we can save them, but it won't be pretty. They removed all of the tissue from her knee to her ankle, all the way down to the muscle. We did borax wraps and Pulsivax, which is borax, like you clean with. We
Mm-hmm.
did that. And then, long story short, 3 weeks later, she was able to walk out of the hospital with both legs intact, but scars from her knees to her ankles all the way around the entire circumference of both legs. And she bragged about it and said, I'm going to tell everybody I got bit by a shark. And so she's like, this is my new shark bite story, because she said, I feel so stupid telling people I scraped my leg on the coffee table and didn't wash it.
Oh my gosh.
It
Okay.
is, yeah, just soap and water. Like, stop what you're doing, soap and water.
Okay.
So, yeah.
A really good recommendation.
Well, it's just so simple. And most people,
Yeah.
they don't realize it, because there was a time in my life before I started in wound care where I would have been like, yeah, it's nothing. And you keep on going because it's such a superficial scrape, but you don't know what is out there. Even if
Mm-hmm.
you're the best housekeeper in the world, you have bacteria because it's a natural part of the environment that we live in. So
Yeah.
I wanted to jump back real quick to the pressure injuries. The other one
Yeah.
that I didn't talk about is called a deep tissue injury. And that is an injury that occurs at the level of the bone and then comes to the surface.
Mm-hmm.
It's a different type of pressure injury. It's would fall into the unstageable category, but this is one that will show up on, like, particularly in the bottom of the heels of the feet, and it'll be a really deep dark purple, and if that shows up, that means that the wound is already down to the bone. The tissue is intact. It feels soft. It doesn't feel mushy or anything. Mushy is the official term.
Okay.
Yeah, I'm kidding. It's not. But it will feel okay, but it'll have that deep dark purple.
Yeah.
And the problem with that is that that is an injury that is already down to the bone. And if it opens up, it is going to be open to the bone immediately. Those will typically end up in an amputation. So if you see that, you do whatever it takes to get rid of pressure. And one of the ways to do that, we see people elevating legs on pillows, which
Mm-hmm.
is wonderful. But keep in mind that if your legs are up, you're putting pressure on the tailbone.
Mm-hmm.
So I always tell people, you don't have to put them 2 pillows high. It only has to be enough so that the heels aren't touching the bed. So that if all you can do is slide this much of your hand, just slide it under the heels, and there's no connection to the bed, then you've got pressure relief. So you don't have to elevate them real high. It's also more uncomfortable. Anybody who is wondering, go put your legs up on a couple of pillows and then just lay there. And after about 20 minutes, your back is going to hurt, your
Mm.
tailbone is going to hurt, and you have a high level of non-compliance because people try to elevate feet too high. And
Oh,
it just needs to be enough to slide your hand under there and make sure there's no contact.
okay.
So there are other things available, like boots that you can put on to relieve pressure, but those are also not terribly comfortable. So if you can do it with just a single pillow, that's really ideal.
Yeah. I'm thinking about the older adults who you mentioned non-compliance,
Mm-hmm.
who just are feeling really put out and tired about the whole thing and don't really want to participate, or someone living with a dementia
Mm-hmm.
potentially who may struggle to remember that A, they
Mm-hmm.
have a wound, and B, there's a protocol that they need to be following. I
Right.
didn't know if you had any like thin slice thoughts on how we can navigate those things.
So that's a great question. I need to
Yeah.
think about that. Dementia is so hard, and at that level, it's not a question of non-compliance. It's, as you've said, it's part of the disease process. They don't know that they have it. And unfortunately with dementia, you can tell them 100 times, hey, you've got this wound, and they have no idea what you're talking about. And I recommend that you don't do that, because then you're just re-traumatizing them with the information, right? You're like, hey, you have a wound and you need to be careful. They're going to be, I have a wound. And every time you tell them that, the reaction is going to be the same, and you re-traumatize them. So please don't do that. Be kind. I would say it would be using the tools available. So getting the pressure relieving cushion, getting the, if it's like you mentioned, the elbow, and we see that frequently in the elderly, because they're, as you age, your skin gets thinner and they kind of rest in that position. So getting things where they're not resting in that position, putting them in the chair so that they can't just put their elbows down. So it's really going to be about having the proper devices in place versus trying to get to a level of understanding or compliance.
Okay.
And then having the right dressing. Do you have a good foam dressing if that's what they need? There are some dressings you can put on that will help with pressure relief for levels of inability or non-compliance.
Sure.
Sometimes it is just flat out non-compliance.
Yeah.
Sometimes it's, I sleep on my back, get away from me.
Right. And I mean, what do you say to that? I mean, this is a more philosophical question, I think, just for all of us as we're.
So if it is someone who is alert and oriented and knows what's going on, and they're saying, I don't care, I will pull out the big guns and pull out a picture of their wound and say, here's what it looks like. Are you okay with that? And then I will pull out a picture of a more advanced wound. There's thousands of them on the internet, and say, and this is what could happen. Oh, and if it gets down to the bone, you could end up with an infection in your bone called osteomyelitis, which is extremely painful, and you will likely die. So if it's someone who knows what's going on, I will just put it all out there. And then I will say the alternative is you sleep on your side for a couple of weeks, we get rid of this, and we're done.
Yeah.
So that sounds so mean, but I think if people don't understand the choice they're making, you're doing them a disservice.
I think that's fair. I interviewed another nurse a few months ago, and she is very direct and to the point for pretty big, hard conversations with people. And I think we do rely on our nurses to have those hard conversations so that the family doesn't have to be the one. So thank you for being willing to do that.
Yes, absolutely. Yeah. And if it's a home patient, I'm gonna talk to the family first and say, do you want me to be the bad guy? Which is almost universally yes.
Yeah.
But sometimes you'll go, well, no, I'll do it. Okay, but be honest. So nobody wants to talk to their mom or dad that way, right?
Yeah.
But I encourage you to let the nurse do their job. And if they're not doing their job, well, get a new nurse. It is our responsibility to effectively educate patients to the level of their ability. And like I said, if they're alert and oriented, we're obligated to make sure they understand the consequences of the choice that they're making. And then at the same time, if they have dementia, it's our responsibility to protect their fragile mental state and look for other options. So.
And I mean, so many of this is deeply emotional, and it's also biology. So I love that you're saying, I have a picture of what your situation is right now, and I can show you where we're headed without the right care and treatment.
Exactly. So the other things to be worried about, we talked a little bit about diabetic wounds. So if they have a diabetic wound, what is their A1C? Are they compliant with their diet? Do they understand that their diet is contributing to this wound not healing? Because if your blood sugars are running too high, your wound is not going to heal. Are they getting enough protein? Are they drinking enough fluids? And that is such a big thing, particularly in the elder population. They just don't drink fluids like they need to. And one of the ways to combat that is, number one, figure out what is their favorite flavor. Flavored water, we have so many options now of zero sugar flavored water. And it's relatively cheap. You don't have to get the high end stuff. I mean, one of the local grocery stores has big bottles of flavored water for $1 a bottle. And they're like 32-ounce bottles. And if you can find a flavor that they like, and then just offer them every couple of hours. And don't make the mistake of offering them big, huge glasses, because that's overwhelming. So if somebody comes up and says, you need to take a drink, and you hand them an 8-ounce glass of fluid, they may look at that and think, well, that's too much. I can't drink that. No, I'm not going to, because it's just overwhelming from the start. So get little small cups and give them 2 to 4 ounces at a time. And just say, hey, I need you to drink this, because this much water is much easier to manage than this much water. So you want to offer fluids every couple of hours. Make sure that they're hydrated.
Put it in a shot glass.
Okay. If that's what works. Hey, if that's what works, hey, Mom, it's time for your shot, the good kind. But no, seriously, it's just all about making it presentable and manageable, and finding something they like without giving them a bunch of sugary sodas, and even too much juice is bad. There's a line where it's just too much sugar is just, whether you're diabetic or not, interferes with healing. So yeah. The other types of wound. Oh, I'm sorry.
Go ahead.
Well, I was going to say the other thing is venous and arterial wounds. So a couple of interesting things about that is, for venous and arterial disease, if you have arterial disease, you likely will not have a bunch of hair on your legs. But the thing that's significant about that is to have that awareness, because if you elevate, and they always tell you, elevate the legs. If you elevate the legs of a person with arterial disease, it can be extremely painful for them. So that is another indicator that there may be some arterial disease going on. Venous disease hurts when their legs are hanging down, and they get the discoloration, like that brownish rust colored discoloration. It's called hemosiderin staining. And it's when iron in the blood leaches out into the tissues and just permanently stains it. And it may look like or resemble a deep tissue injury on a grand scale, but it's not. It's a condition from venous disease called hemosiderin staining. So
that is intense.
It is.
And are these things generated from lack of mobility?
Mobility can play a part, poor circulation, old age. I mean, your venous system gets weaker as you get older. If you, obesity is a factor. So because that affects circulation, diabetes affects circulation. So all of those things, anything that affects circulation, the more mobile that you can be, the better you're going to be head to toe. Right.
Okay.
So in terms of wound prevention,
we've talked about a lot of different stages and types of wounds. Do they heal at different speeds, or is there an expectation as to how quickly something can heal?
Depending on the type of wound, yes. And depending on what level that you get it, yes. So, but diabetic wounds have staging that's similar to what you see with pressure injuries. It's rated a little bit differently. There's different terminology for it, but it's the same concept, of how deep it is going into the wound bed. Again, it comes back to, what is your nutritional status? What is your hydration status? How are your other comorbidities being managed? Are you on blood thinners? Are you controlling your blood sugars? Is your blood pressure under control? Once you look at all of those other big picture things, which is why it is so important to connect with your primary care, because a wound isn't a single issue. A wound is never just a wound. A wound is an indication of some other big picture thing going on with the body. And that's why it's so important to get your primary care involved and get that level of expertise, so they can go, okay, what else is happening here? But as far as healing, if it's a superficial wound, you should, depending on age, you could see healing within a couple of weeks. If it's a deeper wound, you could be looking at months.
Mm. And I'm familiar, there's something called a wound vac.
A wound vac, yes. You put a specialized sponge. Those are usually typically for deeper wounds. And what it does is it's a medical sponge, and it connects to a machine that provides a continuous suction to pull the drainage out. It also brings the wound bed in like this to help add to closure, and it manages the drainage of the wound.
And that can accelerate healing.
Absolutely.
Okay.
Absolutely.
So kind of depending on where someone's loved one is, maybe that's an appropriate question to ask the doctor if that would be a good solution.
A wound vac is typically not ever going to be your first choice. That is something that is going to be for your much more advanced wounds, typically following surgical debridement, where you've actually put someone under, gotten all the junk out of their wound, and then they put the wound vac in.
Okay.
So we hope to never get to that stage.
Okay.
Yeah, the goal would be to avoid that.
What can you share with a family member who has a loved one at home and they're realizing that they are maybe in over their head with wound care?
Get home health on board.
Okay.
You want to get home health care on board because many home health agencies have specialized nurses that know wound care, and that's their job. And they go out and they handle those wound care dressings and those changes and do education with the family and with the patient. So if you're at home and you're like, God, this is too much, I can't do this, you want to get that home health care agency on board to help you out with that.
Okay.
And while they're there, they can also do, so home health also has not just nurses, but physical therapy and occupational therapy. And they can come out and do assessments and go, okay, we can provide this type of cushion or this type of positioning device, or make other suggestions, and also help you get those things covered under Medicare and Medicaid and insurances, so that you as an individual are not trying to go out and buy all of this stuff, but they can help you with all of the processes to get that covered by insurance, as well as the expert recommendations. Because physical therapy and occupational therapy, that's part of their job, is positioning. Mm-hmm. So they play a very big part in wound healing and prevention.
So I feel like what I have learned is it's not always in that senior living environment. It's not necessarily the team to blame. There are so many factors.
Correct.
That can go into a wound developing and worsening. And I feel protective of our team members in senior living.
Yes.
So
there's this tendency to blame nurses whenever a wound happens and say, well, that's nursing neglect. And it's not nursing neglect. You have a wonderful group of people who are working in very demanding circumstances, and not just nurses, but your certified nursing assistants who are doing the bedside care. And no one wants to see a pressure injury occur, because we know that that's a downward spiral for anybody, and it can be painful in the initial stages. So we are as much about preventing that as the family members. And if you find something and you think that the staff doesn't know about it, how about talking? So many people call state. I'm going to report you to state, and they call the state, and the surveyors come in, and I know they have a job to do, but many, many times they come in, the complaints are unfounded, and all they've done is take resources from patient care. Because when a surveyor walks in the door, the nurse, the director of nursing, everybody has to stop what they're doing and be available to that state surveyor and to answer their questions and to look up records and whatever. And all they're doing is pulling resources from resident care. Mm-hmm. So instead of calling state, how about go to the charge nurse? If you don't like the answer, go to the director of nursing. If you don't like the answer, go to the administrator. And then if you still feel like no one is taking care of your loved one, sure, then you call state. But I think you'll find that if you will just communicate with the staff, they care about your people. They care about the people that they're taking care of. It is a very, very rare thing to find someone in long-term care in any level, whether it's assisted, independent, or long-term care, who's just there for a paycheck, because you won't last long. The work is so demanding, and staff members are emotionally vested in these people, even the grumpy ones. Actually, the grumpy ones probably more, because we want to make them happy, and we, in the back of our minds, is this understanding that at some point we're probably going to be a patient in long-term care. And we want to make sure that the legacy we're leaving is a legacy of care, so that that's what we step into when it's our time.
Mm, that's beautiful. I think that's a lovely way to wrap up the conversation.
Well, I have really enjoyed talking with you, Michelle.
You too. I'm okay. So my actual final question is, what is on your playlist? Like, what's inspiring you right now? Are you listening to podcasts or music or anything?
Oh, wow. So that's really interesting. As you know, I'm working on becoming an ordained minister. So everything on my playlist right now is about going back to school.
Okay, fair enough.
Biblical studies right now, Old Testament scripture and theology. So
Well, as a
that's
woman
kind
of
of my
faith,
world.
do you have like a hymn that you love or praise music band that you love?
There is a song called Nothing Else by Cody Cairns. I think it's Cairns. And that song is about just sitting at the feet of Jesus, not expecting anything, just being grateful and saying, I'm not here for blessings. You don't owe me anything. I'm just so grateful to be here. And I try to live with an attitude of gratefulness.
That's fabulous. Well,
So,
I'm grateful that you took time out of your day to be with us here at Inspired Caring, and thank you so
and I
much.
love Inspired Caring, and thank you for having me.
My pleasure.
All right. Thanks, Michelle.
All right. Bye.
Bye.